What if I told you discrimination was happening within one of the most professional settings in the world? When you go into the doctor's office or the emergency room, there is a universal understanding that there will be an accurate diagnosis, but sometimes that is not the case. What are the causes and consequences of discrimination in the medical field? Dr. Ron Wyatt works in the Division of Healthcare Improvement at the Joint Commission, an organization that authorizes healthcare providers across the nation, as the Patient Safety Officer and Medical Director. But this time, he is the patient for a high fever. He met with the physician, and after a substandard exam, he was ordered IV fluids and was told his labs were mostly normal. Wyatt says he needed to ask for more information. After interactions with nurses and physicians, who he never saw again, after being told to take Tylenol at home, the only African American staff he saw told him, "Don't let it bother you," which he took as, "This happens often." Minorities are experiencing discrimination in healthcare, not only face-to-face, but from all sorts of angles. One example, according to Dorothy Roberts, professor of law and sociology at University of Pennsylvania, and an acclaimed scholar of race, gender, and the law, is that African Americans and Latinos are twice as likely to receive less pain medication than whites for the same bone fracture. Events such as the 1972 Tuskegee syphilis study is just another example of this problem. A group of 399 African Americans who had syphilis were part of the study. It was meant to look into untreated syphilis in the body. The participants were never told about what the study really was about and were left untreated for the syphilis. What is troubling is that Wyatt's experience was not another interaction in the 70s, but in 2016. Funded by a grant from the Robert Wood Johnson Foundation, Project Equaled, which stands for Exploring the Quality of African American and Latino/Latino Experiences with Doctors, set up a study approved by the Oregon Health and Science University Institutional Review Board. Focus groups within an African American community were formed to get a sense of people's experiences in healthcare. The participants had diabetes and/or hypertension, so that information was gathered from people who interact with clinicians often. Focus groups of European Americans were formed for comparison. Through these focus groups, more information was concluded. African Americans report lower quality of care and a lack of communication between them and their clinicians. They are less likely to receive types of treatment than whites. The ones reporting the discrimination are less likely to receive health screenings such as mammograms, breast exams, and diabetes blood tests. This affects the quality of care for African Americans. One African American woman in the study described her experience as, "I think it's because I'm a black woman, I do not get no medication or no kind of other kind of treatment. So I'm saying, I think it's that kind of an issue, because you got white druggies. There are all kinds of people who are druggies, but they suspect the African Americans." Another woman said, "They act like they're afraid to touch you or they cannot tell you. They cannot see anything on you, and I have heard a lot of black people have issues with that, where they act like they cannot see anything on you, and a lot of time they will not touch you." In another study conducted by the University of Virginia, researchers looked at a factor for bias. African Americans tend to be undertreated for pain compared to whites, and it is seen that undertreatment comes from the bias that African Americans feel less pain than whites. This study looked at medical students and their beliefs on true and false biological differences between African Americans and whites. On average, the students supported 11.55% of the false differences. Of all the differences given, about 50% claimed one of the misconceptions was at least possibly true. The medical students were also given two medical cases about an African American patient and a white patient and gave pain ratings and the recommended medication. The study shows that people who supported more false beliefs determined the African American patient feeling less pain than the white patient, which also led to an inaccurate treatment recommendation for the African American patient. These discriminations lead to problems within the community. Some people who are minorities decide not to go to clinicians because of a lack of trust. This mistrust can be based off of past experiences or from someone else. This mistrust is a significant problem among minorities. If they do not feel going to a healthcare provider is the best option for them, it can lead to serious health problems. In addition to what people would commonly call discrimination, there is a problem of using race in genetic and medical research. In the past, race has been used to categorize common hereditary traits. The use of race in human genetic research is problematic. There is a difference between ancestry and race. Ancestry is from one's relationship to others in a genetic sense. Race is pattern-based that has led to the organization of people by connecting one person to a socially constructed group. Race is a social grouping that changes and varies. In a personal interview with Dr. Sarah Tishkoff, the David and Lynn Silfen University professor in genetics and biology at the University of Pennsylvania, holding appointments in the School of Medicine and the School of Arts and Sciences.
Race is not as specific as ancestry. There can be problems. Somebody talks about a Hispanic race, and somebody could have, who maybe even self-identifies as Hispanic, could be have varying amounts of European or Native American or African ancestry. It's not going to be super precise. So you can get more precision perhaps by asking someone about their ancestry, going back to, say, their grandparents. And you can also use genetic data to infer ancestry.
In a White House event in June 2000, the map of the human genome was revealed, and President Bill Clinton claimed,
"After all, I believe one of the great truths to emerge from this triumphant expedition inside the human genome is that in genetic terms, all human beings, regardless of race, are more than 99.9% the same."
This breakthrough shows that there is no reason to separate genetic studies by race. A part of the problem is that humans do not fit the biological guidelines that are recognized. Interbreeding makes groups heterogeneous, so racial assumptions can lead to misdiagnosis. In an interview conducted by Angus Chen from NPR, Dorothy Roberts and Dr. Sarah Tishkoff answered questions about using race in medical research. Roberts stated that using race in medical decisions leads researchers down the wrong path and leads to harmful results for patients. Different people have different genes that work on drug metabolism. It can be seen that there could be high gene frequency for a racial population, but it becomes a problem when it is assumed that one person has the genes for a drug just based on race. From information gathered through an interview and a TED Talk by Dorothy Roberts, minorities such as African Americans are treated different than whites. The history of this problem started with slavery and with biases used to justify slavery. Dr. Samuel Cartwright, an University of Pennsylvania alum, practiced in the South in the antebellum period. He was a proponent of the idea that slavery was actually beneficial for the blacks forced into work. He claimed that the blacks need the labor because of lung deficiency. He stated that red blood cells are sent to the brain that liberates them when in forced labor. Cartwright even created a medical device called the spirometer to show lung function in blacks. Doctors today still use this device with an adjustment for race. This is a detrimental problem because these biases are in place and opens up medical decisions to be based on race. In addition, doctors are just as much a part of society as the rest of us, so they are not immune to believing and using stereotypes. Doctors have said they use race as a shortcut. It is used as a way to conclude factors such as muscle mass that they do not have time for. This is inaccurate, with race adding no information in many cases. Sometimes race overshadows the research. Factors such as the patient's history and illnesses are ignored in these cases. More specifically, there is a heart disease drug called Bidil that is specifically for African Americans. It is made out of a combination of isosorbide dinitrite and hydralazine hydrochloride. This became the first race-specific drug approved by the FDA in June 2005. There are some dangers for a drug like Bidil. It treats African Americans as genetically different than whites. The drug was tested just on African Americans, but the drug cannot be used on other races. Other drugs have been tested on majority whites they can be universally used. This implies that the normal type is white, with African Americans being different and needing their own drug. Something can and is being done about this. Dr. Tishkoff stated,
We know that people differ in terms of variation in genes that play a role in drug response. Now, ultimately, the long-term goal is to have personalized medicine or precision medicine, where once we have genome sequences, then, we can look at whatever gene is of interest, maybe a gene associated with drug metabolism, and we can figure out what variant someone has of that region on an individualized basis.
there now needs to be a change in the way biologists conduct research and investigation. Scientific journals can be the start to the solution. Vocabulary is a significant part of changing the opinion of the public. Using words such as ancestry and population to define groupings and defining variables used in the study can help readers understand genetics and race. According to Dr. Tishkoff,
People should just stop referring to groups by a racial classification and stop calling them races.
Dr. Tishkoff believes people should refer to ancestry when possible.
Cases where race actually is informative, and that has to do with when you're looking at health disparities research, say access to HealthCare.
Race can influence how people are perceived and treated and can be associated with socioeconomic conditions which can impact healthcare.
But for genetic studies, it's better to avoid that and to talk typically as possible about ancestry.
Unfortunately, attempts so far have only been in small parts, so it did not have a lasting effect on the problem. Scientific journals changing vocabulary and clarifying variables would then lessen confusing use of race and genetics. Discrimination in healthcare is not just a physical problem for patients, it is also a dark mark on America. With the country's history and the media displaying acts of racism and discrimination, this just adds to that and needs to be fixed, especially in a field as important as healthcare.